Drug delivery. Hi everyone, this is Vasantha. I'll be talking about common mistakes in glaucoma management. So do we really commit mistakes? Yes, obviously. If we try to search for them, you will find a big list. So I tried to miss my mistake. I'll reveal it. So my mistake. So while dealing with this patient, I forgot to ask about the history of topiramate use in this patient. So can I say and escape to err is human and try to erase the mistake? Can I do that? It will worsen the situation. So if I start making a list, it's becoming very big. It's not even included in this list also. So sometimes we think that it's a very small mistake, but even then it can lead to big consequences like blindness. So that is irreversible, black hole of irreversible blindness. So if you will wonder if you know that it is sitting like a time bomb on us. So why to bother about our mistakes? Because it has got medico-legal implications. If we look at this data of Westlaw, about 40% of the cases involved allegations for the mismanagement of failure in diagnosing and treating the glaucoma cases. So which are more than the surgical errors. So if we see here, disproportionately high awards are being granted for the glaucoma malpractice. So which is keeping us in a peculiar situation, unique litigation. When you compare ophthal and glaucoma also, it's almost equal, keeping the glaucoma in second rank. So the objectives of this session is participants at the end of the session will be able to list out their own mistakes and errors, and also they get sensitized to the medico-legal implications. There are many types of errors that we commit either in planning, that is, we try to treat the neuro-ophthal case with the anti-glaucoma medications, or errors in executions by omitting or committing. So error of omission means we record intraocular pressure in one visit, or we don't do 10-2 in advanced glaucomas. Error of commission means we prescribe prostaglandins in cases of uveitis and unilateral glaucomas and pregnant ladies. So is this an error of omission or commission? Doing trabeculectomy this is a question for you. Doing trabeculectomy in morning glory syndrome. Omission or commission? It is definitely a commission, no? Doing a wrong thing. Thank you. So which gets included in the glaucoma surgery settlements where unnecessarily surgery is being done. So after reading this chapter in this book, that is Chandler and Grant's, I got an idea. That means this is a never-ending topic. On last day of my breath also, I can keep on preparing my list. So this can be classified as missing the diagnosis, incorrect diagnosis, treating, over-treating, under-treating, or insufficient communication with the patient. So sometimes we miss the diagnosis by not taking proper history, like steroids and trauma. So there is a joke in a book by clinical epidemiology by Sackett, that is, a patient goes to all the doctors in the town and goes to a gastroenterologist, and he says that only one thing is left over, that is history and physical. So they are all ready with all the reports. Patient came with all the reports. So some of the points patients won't tell us, even we don't ask in the history, and we'll miss. And you'll be wondering, you'll surprised to know that even subspecialty people also, they try to forget, asking in the history about the steroid use. Finally, they will land up in steroid-induced glaucoma. So this is a public health problem, but parents and patients are also, they are not filing cases. That's why we are not looking at the steroid-sparing agents in some conditions. And we miss the history of asking about trauma in some cases, and we forget about asking about beta blocker systemic use. And sometimes we use the slit lamp as a torchlight also and miss some of the findings. And we use surrogates also for gonioscopy and do mistakes. And sometimes we conveniently make the assumption that looking at a shallow AC, we call it as a closed chamber. Looking at a deep chamber, we call it as an open angle. But the evidence suggests that only negative predictive values can help us in these situations. And we also forget that we have got unique eyes. And we always say that POAG is more common, and we try to forget that blindness is more common with PACG. And many of the malpractice claims are related to YAG iridotomy also. And we miss the diagnosis by not using a correct tonometer to that particular condition. And we start saying that anyhow, angles are very open, Anyhow, we have to do cataract surgery, we need not bother, we can bother about glaucoma later. And we do some mistakes because of the lack of knowledge about the corneal behavior. Sometimes we are scared of dilating also in angle closure suspects, and miss the diagnosis like diabetic retinopathy and some other important retinal condition. And we miss the difference between the color and contour also. And we forget to recognize the neurological fields in a case of glaucoma. And GRED sir was talking about red disease and green disease. So because we go by color only means, that's all. We will be in the soup. So we should never get fooled. Sometimes we misinterpret, angle closure as open angle glaucoma. So we forget that there is a master of disguise. And even Chennai glaucoma study also revealed that we missed many angle closures. And we try to undertreat advanced glaucomas also. We'll be happy with high teens instead of going to the low teens. And I told you about 10-2 that we missed in advanced glaucomas. So once you see 21, we start treating every patient. So many suspects, we start treating them unnecessarily. That is a big mistake. And sometimes we don't treat the green disease. And most of the mistakes are related to medical. And we don't communicate also properly with the patient. And we just go by with signature is enough for us with patient's consent without even talking to them. Can we tolerate if the patient says in the court, I didn't even see the doctor until the day of surgery? So the defensive medicine model is a very wrong one that we follow even now. So on patient safety day, they have emphasized about the shared decision making model. That is, we need to elevate the voice of the patients. So finally, if we want to reduce the mistakes, you have to pay attention to the complete examination, documentation and counseling. Sometimes patients don't use drugs, no, they are not complained. That also has to be documented. Comprehensive examination means, I remember only Professor Ravi Thomas always, not like this, sometimes we try to do like this, I know. So not only the patients suffer with the glaucoma, even we have to suffer if we don't take care of our mistakes and try to jump and fix it. Even in the clinical audits also, we pay attention to the individuals instead of the errors. So let us pay attention to the error-prone systems and try to understand that even a single mistake will make a lasting impact on the quality of the life of the patient. Thank you.